Archie Strachan in 1929, long ago, was the first person to describe increased iron in patients with liver cancer. You can see that 66% of his patients who had liver cancer, he was a Scottish physician working in Africa, found that 2/3 of the patients actually had more iron when they had cancer compared to when they did not have cancer in the liver. These were autopsy studies. Unfortunately, he didn't get any credit for his work for various other reasons. I would recommend you read this article. It's an open access article, and it has been reanalyzed and republished in 1996. So this concept is not new. This is one of the more recent publications, the role of iron in tumor cell proliferation. Iron is a double-edged weapon. Actually, everything is: salt, cholesterol, physical activity, everything. We all have a U-shaped curve. If you have too less, it is harmful. If you are in the optimal range, it is good. If you have too much, it is harmful. And so it is the case of iron. Iron excess may increase the risk of developing cancers because it helps in generating reactive oxygen species and participate in cell proliferation. So the real interesting thing is whether by depleting iron could we help it as an anti-tumor therapy. And iron has been shown to cause, increase the risk of cancer in hemochromatosis, viral hepatitis, and some of the other conditions as well. So the real question is it cause or confounding? In other words, is the iron increased because of the disease, or is it that iron is actually increasing the severity of the disease and causing cancer? And the other thing from a therapeutic point is, by restricting iron, can we alter the natural history of the disease? So I just quickly go through some slides, not going into the details, but just trying to emphasize the point. One of the earliest works on this after Archie was by Professor Bloomberg, who passed away last year. He's done a lot of work. This is increased serum ferritin as a risk factor for primary hepatocellular carcinoma. This was a work done in Korean patients. Then we have a more recent work from Italy, liver iron excess in patients with NASH who had liver cancer, again showing that increased liver iron increases the risk of liver cancer. This is an interesting study looking at the liver iron content in explants in more than 500 patients who underwent liver transplantation, of which about 482 patients actually had HCC. And they found that the common cause of HCC was hepatitis B in about 17%, hepatitis C in 15%, hereditary hemochromatosis in 15%. And they concluded that iron overload was significantly associated with HCC after adjusting for etiology of the cirrhosis. Another recent article from Gastroenterology, the highest impact GI journal, iron levels in hepatocytes and portal tract cells predict progression and outcomes of patients with chronic hepatitis C. Here they looked at the presence of iron in the portal tract and in hepatocyte and found that those who had high iron had progression in terms of Child-Pugh score or ascites, encephalopathy, bleeding, and HCC than those who did not have high iron deposits. And they had adjusted for the mutations and this did not correlate with the outcomes. And iron nitrites at baseline increased the risk of outcomes. Of course, this is not only cancer, but it included several other outcomes. So does it really mean, as I said in the beginning, confounding or causal? This is a meta-analysis of 6 randomized trials, prospective randomized trials, where they actually did phlebotomy. This has been an increasing work, particularly with the Japanese, and some studies have been done in other parts of the country as well, where they looked at the impact of phlebotomy in improving the therapeutic response to interferon in patients with chronic hepatitis C infection. And sustained viral responses were much better when they subjected these patients to phlebotomy and brought their iron levels down. So this is yet again a thing that is indicating that we may be, iron has a role to play. And this is a very recent publication from the clinical cancer research. Iron deprivation suppresses hepatocellular carcinoma growth in experimental studies. Here actually they did lab studies looking at hepatocellular carcinoma cell lines and HFE knockout mice, and they suppressed the iron using a potent chelator and found that actually suppressing iron resulted in cell cycle arrest, apoptosis without toxicity to the cells at effective doses. So this again is a proof that iron has a role to play in the carcinogenesis in patients with chronic liver disease. One of the things that has always bothered me is that why this big difference between India and China. India has a liver cancer rate 2 to 3 per 100,000 population. China has a 50 times higher rate at 100 per 100,000 population. This difference is huge. You can just see this 2 to 100. And what has, after much thinking, we felt that it could be, one of the reasons could be that iron deficiency is rampant in our country. One of the reasons, and I'll come to it. What is happening all over the world and also in our Ramchi, Mumbai, is that liver cancer rates are going up. These are age-adjusted rates using the world population. In the 60s, that was the liver cancer rate, 1 per lakh population. Now we are up about 4 times. And so liver cancer is actually now, if you see, catching up with esophagus, stomach, colon, rectum, it's more or less the same level. We are going, more and more patients are getting liver cancer. And what could be the reasons? One of the reasons is, as we thought, that it could be to do with the rampant iron deficiency. Most Indians experience iron deficiency at the beginning of their life when they are conceived, in the childhood years, adolescent life, till end of their life. So we have 87% of women, pregnant women in this country who are iron deficient, 75% of children who are iron deficient, and of course a whole lot of adults as well. A WHO survey done many years ago in the 60s found that the iron content in liver specimens of Indians had the least amount of stainable iron. And I just show you this slide. This is from the study which was quoted by the WHO. They had fair number of patients. These are all autopsy studies, and you can see that the amount of iron in the Indians from Delhi was much lower than other places, and of course the Bantus in Africa had the highest. This same thing has been found in the UK, in Singapore, among the Chinese, the Malays, and the Indians. Indians have the least amount of iron. So we had this hypothesis that the rampant iron deficiency is actually protecting our patients from developing liver cancer, and that's the reason why liver cancer was low, and now it is rising because the iron deficiency is slowly getting corrected in our population. Plus we see much more liver cancer among the affluent as compared to the poor people. So we have started a couple of studies. I'll present the result of a case-controlled study. We screened several patients. There were 283 patients who were screened who fulfilled the criteria. We had 116 patients cases, and these were the controls who did not have cancer. These were the cases who had hepatitis B or hepatitis C related hepatocellular carcinoma. And what did we find? I'll go straight to the multivariate slide for want of time. We found that, like all other studies, coffee drinking was protective, so the odds ratio is less, but increased hepatitis, older age, lack of anemia, higher socioeconomic group, tobacco use, male, and alcohol use, all of them, there was significant increase in the risk for hepatocellular carcinoma. But when we look at iron, we measured the iron using ferritin for various reasons. One of them being that it was the cheapest test that we could afford within our funding, and we did consider the other tests. But when we compare the low ferritin, that means levels below normal, to various levels, low normal, and then this is high normal versus low ferritin, and high low ferritin versus high ferritin. That means above normal range of 200. And this was adjusted for both men and women separately. You can see that there is a huge increase in the risk of hepatocellular carcinoma in patients who are having higher, even high normal ferritin and very high ferritin. This is not yet published, it has been presented. So this, as we were doing these studies, a couple of other interesting papers appeared. This one in the famous New England Journal of Medicine last year. 10 patients with advanced hepatocellular carcinoma not responding to chemotherapy were treated with iron depletion using desferoxamine, and they had patients who responded, and the overall response rate was higher than what was achieved with sorafenib. Just to give you the slide, you can see these lesions in the liver improved, the lung metastasis improved with just simple iron depletion, and alpha-fetoprotein levels as well improved. The survival was much better than what is approved. And then this study, which is published again in hepatology, looking at ferritin and outcomes of patients waiting for transplant, they found that a ferritin more than 200 micrograms at the start was an independent predictor of mortality as they waited on the transplant list, indicating that ferritin is also a prognostic marker, and this was independent irrespective of adjusting for the MELD score. So there are randomized trials now started. This is a study, phlebotomy to reduce the risk of hepatocellular carcinoma and alcoholic cirrhosis. This is a multi-center French trial, and encouraged by this, we also have started a randomized trial. So this is my summary slide. The most important issue is, does iron help in increasing liver cancer and whether we should be reducing it? Should we be avoiding iron supplements in our patients with chronic liver disease, and also advise them not to use iron-rich diet and avoid fortified foods? Whether iron chelation would help in patients who have advanced cancer, and whether ferritin can also be used as a prognostic biomarker for those who are waiting on transplant list, and also for screening, because people with high ferritin are more likely to get liver cancer, so maybe they need to be screened more frequently and more intensively than those who don't have high ferritin. These are just some of the questions. Thank you.